Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I have the pleasure today to be talking with Chris Beck, who is Vice President of Operations at Union Hospital in Dover, Ohio. He is responsible for oversight of the employed physician network at his hospital. Chris, it's good to be talking with you this morning.
Oh, great, Larry. I appreciate your time.
So, Chris, could you tell people, kind of go back to the beginning of your experiment and kind of paint the general picture of how things were at the beginning and then how they evolved?
Yeah, absolutely. So, if you rewind probably now 5-6 years ago, we were still a independent hospital, a 111-year-old organization, a small community hospital. We have about 108 beds. We're licensed around 150 beds, but we staff for about 108 beds. And ultimately, we were at a point, and especially I was at a point, where I was in business development and government relations after coming out of clinical operations and almost feeling a little bit demotivated from the standpoint, what is there left to do in healthcare? And ultimately started to work with some local self-funded employers. We held focus groups with them. We held focus groups with local brokers and benefit consultants, and then we also held focus groups with our employed physicians and independent physicians in our community. And ultimately, what we found is we knew the move to value in population health management was coming, but we also knew that due to our size, we were not going to have a large number of payers knocking on our door saying they wanted to get into creative contracts with us. So we knew that on the front end of value, the move to value in population health, there was going to be a great deal of learning and education and experience that would come out of being on that front end of that curve. And we didn't want to miss out on that because of our size. But we were also blessed from the standpoint of an amazing medical staff, both employed and independent, and being a community hospital and a community asset to our local self-funded employers, of which were very forward-thinking, those employers. We had a perfect test base, so to speak, to try to create a model that did exactly where the industry hoped to go, which was move to value. So through those focus group sessions, what we came out with was, again, small community hospital, by no means were we prepared to take on large capitated risk, but what could we do? What could we do from a comfortable risk point to drive that value proposition? And ultimately what we came out with was a capitated model for what we coined high-value preventative care. And that high-value preventative care, we can kind of talk about what goes into that, maybe here in a moment.
Great. And then how did the idea of direct primary care as the sort of business model, how did that come into the equation?
Yeah, so even earlier on, we were working with one of our local self-funded employers who wanted an on-site clinic. So I started to do more and more research into that, and I had always found, almost all through my career, for whatever reason, I was always kind of an employer advocate. I just found that to be such a unique scenario for hospitals because they control their spend, they control their claims data, and it's almost they control that population. So in population health, one of the most difficult questions, whether you're doing a Medicare or a Medicaid contract or anything like that, is, oh my goodness, where is my population? It's almost to the wind. They're in all these different circumstances. Well, when you work with a self-funded employer, those circumstances are sometimes very similar, and you have a very much captured audience because of a benefit plan. So we were working with that one employer who wanted the on-site clinic, and as I was researching and attending conferences, trying to know as much as I could know about on-site clinics, realized that due to the size of many of our self-funded employers, because we're a small community, they didn't have that critical mass number of maybe 750 to 1,000 employees to really maybe drive the return on an on-site clinic. So because of that situation, we started to look at the direct primary care model with the help of Employer Advantage Healthcare Solutions to help us with the claims data and the creation of the model. And we had to come up with a system that could still work for self-funded employers, but they didn't have to invest so much up front as many do with an on-site clinic. So that's how kind of that concept was born, out of really scope and scale that met the needs of our local businesses.
And can you talk then about, so now you've got a self-funded employers, you've got a network of physicians, and you've got a business model. So how did you bring all those together, and how was that received by the physicians?
Yeah, that's a great question, and I can almost feel it, like I'm going through it again as I'm recalling it. At first, there was a lot of head scratching because it was really changing the service delivery model. It was divorcing ourselves from, I guess what could be coined Medicare medicine, or removing ourselves from that being tied to CPT codes, so that way we could get more people involved in the care team, not be so concerned about reimbursement, because the capitated model is a payment in advance of care. So we were able to take that payment and invest it differently. And once we started to kind of explain to our physicians, and they were again involved in those focus groups, and they were learning from the employers what meant and what drove value from the employer's perspective. Once they realized that, hey, if you did not have to worry about coding and reimbursement, what would you do differently? And oftentimes they would say, well, I would want a nurse to be on my team that could follow up with them. I would want a behavioral health counselor to be on my team that could meet and counsel with folks. I would want a nutritional counselor that would be on my team that could meet and counsel folks the same way. And I said, well, we can do that. And that's kind of how we were able to bring them to the table. On the employer side, again, I said it earlier, we were blessed because we had such forward-thinking employers, not to mention our own benefit plan, where the hospital was the largest employer in the community, so we tried it on ourselves before we tried it with anybody else. And ultimately, everybody kind of rallied around that concept.
So could you expand on that a little bit more? You tried it on yourself first. So how did you do that?
Yeah, so what we did is, we have an 80-20 plan here. We are a self-funded employer ourselves, the largest in the county. We also have a high deductible plan. And what we did is we worked with our TPA, and what we did is we wanted this direct primary care model to not be its own plan, but rather be a benefit enhancement that sat on top of both of our current plans, the 80-20 and the high deductible plan. And probably for another conversation another day is the intricacies of the high deductible plan, and how you have to be careful based upon coupling that plan with health savings accounts. But ultimately what we did is we rewrote our summary plan descriptions for each of those 80-20 and high deductible plan to include this enhancement, and we made it voluntary. And it started off with just a little bit of interest from folks, and now we have about 50% of our eligible lives in the model. And what the model is the benefit plan pays our primary care network a per member per month fee for those that are engaged and enrolled, and we can talk about engaged here in a moment. And if they are engaged, the individual, they do receive discounts on their premiums, and then they're able to access all of the services listed within our high-value preventative care model with no fee to them, so no copay, no deductible, and that's exactly how we tried it out on ourselves. Then because we're a self-funded employer, with the help of Employer Advantage, all of our claims data goes to the data warehouse that Employer Advantage operates for us. My nurse navigators have real-time access to that database, and they're able to run and generate reports all the time, create disease registry lists and follow-up lists that they act upon.
Chris, could you say a little bit more about that issue of engaged versus enrolled?
Yeah, absolutely. So, because it's voluntary, somebody does have to raise their hand and say, I want to be a part of that DPC model. And then there are, our nurse navigators then sit down with each person that has first enrolled, and they go over the expectations of what it means to receive that benefit and to also earn the premium discount. And what it is they have to go through what we call an organizing visit protocol, which is the first session with the nurse navigator, goes through a very detailed H&P, probably draws some labs. They also are sitting down looking at the claims data for that individual to see if there's any really risky situations that are out there that maybe need to be dealt with immediately. We risk stratify that individual based upon their claims data and their clinical disposition, and then after that, that's the initial visit, which is with the navigator. Of course, that navigator can pull that physician in immediately if there is something risky that's going on. If not, then we go ahead and schedule the first appointment with that physician, where the navigator then tees up the entire disposition for that patient with the primary care physician upon that first meet and greet. So as long as that individual carries out both of those steps, they receive their premium discount. And then to maintain that, the individual has to show continuous effort towards carrying out mutually the care plan. And that some of that is a little subjective, so listeners may say, well, that does sound rather subjective, and it is. But ultimately, that is driven by the care team. Deciding, okay, is this individual engaged? So you have two very objective components of engagement early on, which is attend the organizing visit protocol, attend the physician's first appointment, and then thereafter it's a little more subjective, that you have to continue to play your part in the care plan. It's not about getting the blood pressure down or getting weight down or anything like that, so it's not those types of outcomes driven. It's more, hey, are you really participating in the care plan? Are you trying? So that's how we gauge engagement, and then that's what ultimately plays its part into the premium discount.
Great. And can you speak to results? What are you seeing in terms of the impact on patients' health and cost issues?
Sure. So we'll start at the very beginning. One of the largest things that we were concerned about, because when we first decided to do this model, what we did is we had to create a baseline. We took 3 years worth of historical claims, and we put them into Employer Advantage's data warehouse. And at that point in time, then we were able to really take a look at things and see where our spend was. Well, one of the things we realized, which was always a concern, was what we call the medical homeless rate. So in healthcare, and this happens for a lot of industries, but probably healthcare sector is even more known for this, is self-referring, because maybe you're a nurse, maybe you're a technologist, a medical assistant, whatever the case may be. You're pretty bright when it comes to the healthcare landscape. So what happens is oftentimes you do not see your primary care doctor and you just self-refer all the time to maybe specialists. So what we did see and what was confirmed was a 62% homeless rate, medical homeless rate, amongst our caregivers here at Union Hospital. That was a major concern, and what that rate meant was there was no meaningful relationship between themselves and a primary care physician. So what we wanted to do was definitely have an impact upon that, and of course we did, because if you go back to what an engaged individual meant in this model, not only did they have to initially see and develop that relationship with their nurse navigator and their primary care physician, but they had to be an active participant in their care plan. So immediately, for 50% of our lives, that medical homeless rate went to zero. So that was an easy one, some could say, but it still took a lot of design and effort to get to. Some other outcomes is that we now have 3 years worth of data on the lives that are in the DPC model, and those lives are 23% less costly to care for than those that are not enrolled in the DPC model. And it's good to know that we are comparing apples to apples there. So that per member per month rate that we're calculating for the DPC lives also includes what the benefit plan is paying the primary care providers per member per month to roll this model out. So even after you have that investment of primary care, it's still 23% less costly to care for than those that are not in DPC. And that was a really important outcome for us, one of which some employers have a tough time swallowing, because when you look at a lot of benefit plans, when you break out their spend, what you may see is 3%, 4%, if you're lucky, 5% spent on primary care. And ultimately, our selling point is what we want to do right off the bat is double your spend in that one category. And there are employers that will ask you to leave right after you say that. The others that say, okay, well, let's give it a shot, will hopefully see the same outcomes we've seen, which is, we doubled the spend for primary care. We doubled the investment in primary care, and what that's done for us is allowed those lives to be 23% less expensive to care for. Some of the arguments that are out there is, well, do you have selection bias? And that was also, I'll admit, that was a concern of mine as well. Do your healthier individuals participate in this because maybe to the lay individual, do they see this as a wellness program? And oftentimes when you read research, you see that those who participate in wellness programs are typically those that are well to begin with. And what we find in our data is that 88% of our DPC covered lives have multiple chronic conditions. And that's compared to 95% of our lives that are not in the DPC model. So that's, in my opinion, those are pretty similar characteristics. Yes, there's maybe a fewer individual with multiple chronic conditions in DPC, but it's not a large difference, 88% versus 95%. And I should clarify that when we're talking these lives, children are not included in this, because typically that's not where your spend is. And unfortunately, if you do have a high spend within your child-covered lives, that is not usually a spend that you can impact through care coordination chronic disease management, and the typical things that you deploy in an adult population. So when we're talking about DPC versus non-DPC, we're really only talking about the adult lives that are in the plan.
So I have to say, Chris, that the numbers are impressive. What's been the response from the docs?
Great question. So our docs love when they see a DPC patient on the schedule. So that's actually another quick point that I'll make. Probably the biggest challenge we have right now, Larry, and probably those that are listeners as well, is we are working for two masters, it feels like. We've got some of our lives that are in value-based arrangements because we also we are participating in CPC Plus Track 2 for all of our primary care practices, so we were very blessed that we had that opportunity through CMS. But still, the majority of our revenue and the majority of our lives are still normal, traditional fee-for-service. So there is a challenge in doing that because it does feel like you're serving two masters. But from the standpoint of our providers, they do love knowing that those DPC lives are coming in because they know those lives have been acted upon, that care plan is going to be updated and acted upon by our nurse navigator, our behavioral health counselors, our nutritional counselors, by a pharmacist that's contracted to do medication therapy management for those lives. So they know that, I don't have to really worry about coding and making sure that we're going to get reimbursed for something that I want to do for this life because they know that we're already being paid in advance for that care.
Gotcha. So what kind of, are you measuring clinical outcomes?
We are moving towards that. So what we had access to probably within the first 2.5, 3 years was really, truly traditional claims outcomes. And what we're moving towards, we're going through an EHR conversion now with our new partners with the Cleveland Clinic moving to Epic. There's going to be a ton of resources available to us through that conversion, and we're so excited about and so thankful that we have that opportunity through our new partnership. But then also with Employer Advantage will be the access to a clinical tool that's helping us to dive into our ER utilization, maybe our readmissions that we have. And actually, we just had a meeting here not too long ago where we had a couple readmissions. So I was able to just put one of my navigators on that. Okay, I want a full disposition on what occurred there. So that way we can see, okay, was it a failure on our part or was this something that we just could not foresee? So we're able to have really good conversations and continuous improvement conversations on those lives. And we're hoping to get a lot better clinical data based upon our move to Epic and the use of the other population health tool through Employer Advantage.
So, Chris, it's my understanding that your model has been so successful that your hospital has been able to turn to other self-insured employers and offer this service. So you've essentially created if you like, a service line with revenue coming in from primary care. Is that accurate, and could you comment on that?
Yeah, so we've been able to roll out a direct contract with 2 other self-funded employers in our market. So including our benefit plan, we're now working with 3 employers, and there are others that want to do something. The challenge we have is what most hospitals are having right now is the recruitment of primary care providers. So we did go through a point in life here within our community where we lost 7 or 8 independent primary care providers in our community. So we almost had to kind of stop bringing any other employers on board until we could create the access that we need for the entire community and not do so just for the employers, because we are a community asset first for our county and those contiguous areas as well. So we are going through, again, being a new partner with the Cleveland Clinic, we're amazed at the number of recruits we're now able to have in front of us. So we're hoping to recruit a good number of primary care providers with the ability for us to then create more models for employers here, hopefully in the next year. One of the other challenges that we're looking at right now is because we're a small community, we do have some self-funded employers, but there's fully insured employers, and that's been one of our goals all along is let's cut our teeth and let's learn how to do this with self-funded, because we're going to have access to their claims data, and ultimately they are the controller of their benefit design. But as far as fully insured employers, boy, what could we do there? Are we able to work with maybe a TPA or to do some sort of catastrophic plan, and then see if we can't do a direct primary care model where that TPA can carve out the cost of primary care, because that fully insured employer is going to be paying for that directly, and then charge them a less costly premium on a catastrophic plan. Just trying to generate ideas on that right now.
Great. And as a final question for you, so the Cleveland Clinic and you are now in a relationship. Could you share your thoughts about why the Cleveland Clinic found you an attractive partner?
Oh, great question. Yeah, I appreciate that question. So we're a 112-year-old organization. We remained independent for quite a while others were not able to be so lucky. And our board was very forward-thinking at the time, that said, all right, we still have a healthy margin. We still have money in the bank. Our bond covenants are good. We see the writing on the wall, though. Leverage is going to be a challenge with payers. So we did go ahead and decide to send out that RFP, and we were very blessed at the return. A great number of folks that had interest in us, and ultimately, the decision came down to, if you're going to choose a partner and the best in the world is on that list, you're hard-pressed not to go with the best in the world. So we did make that decision. The board made that decision for us, and it's been an amazing ride, really a world-class organization. And ultimately, as they talked to us, they said, you are, Union Hospital, you're one of the lower-cost providers in the state of Ohio, and your quality is excellent. And ultimately what their thought process was, as we move to population health, we need to be able to, as an enterprise, is care for populations in their communities and drive that value proposition. So what that meant was at the lowest cost point with the highest quality point. And, we've been trying to operate that for a long time. The challenge just is in healthcare, the revenue's dropping. It was difficult to do that on scope and scale when you're a small independent organization. But then all of a sudden you begin working with an amazing partner with the Cleveland Clinic, and you're able to now work on scope and scale. So we're real excited for that opportunity.
Chris, you shared with me at other times another important outcome that you're seeing on the inpatient side in terms of the results of the different care delivery. Could you comment on that, please? Share that with us.
Yeah, absolutely, Larry. So one of our premises was, as we talked about before, is if we're able to work within a model where we can increase the investment to primary care, the premise is that we're going to be able to help control care, coordinate care, manage care well enough that we may have an impact in inpatient spend. And so far, 3 years into this pilot project, what we've noticed is if you take your those folks that have enrolled in the DPC model, and they have their own healthcare spend, their own PMPM, and then you take the non-DPC lives, and they have their own PMPM spend. And if you remember that both sets of populations had very similar percentage of lives with multiple chronic conditions, where the DPC lives have 88% of their lives have multiple chronic conditions, whereas the non-DPC lives, 95% of their lives have multiple chronic conditions. And what we're finding now, 2.5, 3 years into this program, is that on the DPC side, those that are being impacted by the whole team-based medicine, 27% of their per member per month spend of total claims is on inpatient care, whereas on the non-DPC side, those are going through your normal traditional fee-for-service benefit plan, 73% of their spend is on inpatient care.
Chris, that is truly impressive. And would you attribute that all, from my perspective, in the direct primary care community, the employees who receive DPC care, their docs are able to spend more time. The process that you've created that supports both the patient and the doc is so robust. Is that what you think accounts for the difference?
Larry, yeah, that's a great question. Ultimately, what we've seen with our 2.5, 3-year project here is the ability to invest in primary care for those that are enrolled in the DPC model has had a pretty significant impact on our inpatient care spend. So ultimately, I'll remind everybody that those with multiple chronic conditions in both the DPC population and the non-DPC population is pretty similar. 88% of those in the DPC population have multiple chronic conditions, whereas 95% of those in the non-DPC population have multiple chronic conditions. But ultimately, what we're seeing is the inpatient spend is much higher for those that are not being acted upon the new team-based medicine model. So if you look at our entire inpatient spend for both groups, so you add DPC's inpatient spend to non-DPC's inpatient spend, 73% of that spend is being accounted for those that are not in the direct primary care model and not being impacted upon by the team-based model, whereas the remaining 27% is being spent on those that are in the DPC model. So we find that to be a pretty interesting outcome, one of which that we would love to try to duplicate elsewhere, and also one of which that we're keeping a really, really close tally on.
So from my perspective, Chris, what you're describing is well-coordinated care, team-based care, with the right incentives for the patients to participate versus uncoordinated care where a group of people getting the kind of traditional and usual care. So there's a real impact of difference in those models.
Absolutely. You know, in putting this together 5 years ago, 6 years ago, that was, of course, the premise. And, you know, with an N of 1, meaning, you know, an employer benefit plan with 3 years of experience that's only one benefit plan, that's what we've seen right out of the gate.
Fantastic. Well, Chris, I want to thank you very much for sharing this information with us. And if it's okay with you, I would like to be able to add your email address to this broadcast so that people who are interested in learning more might be able to contact you. Would that be okay?
Oh, yeah, Larry, I'd happy to.
Great. Thank you. So, Chris, thank you very much, and I look forward to more conversations in the future.
Thanks, Larry, and good luck to you guys.
Thank you. Okay, Lisa, you